Okay, so I know some of you guys are recording the lecture. That's great. I'm going to record it as well and try to share it with some of the folks that are out today. And so we're going to be moving into Module 5 where we're going to talk about head trauma. So how do you know when a person, other than obvious injuries, what are some things that you would look for in a person with a traumatic brain injury, also known as a TBI? So you can potentially see blood coming from the ear. Good. What else? So tell me more about the pupils. So what else in particular with a TBI? There may be a little bit of reactivity there, but what would you see that would be really, really different? Say it again now? Yeah, so they would be unequal. When I worked in Dalton, we had a billing secretary that worked for us who had a permanently dilated pupil, so it was always blown. We always used her in the scenarios for head trauma. And, you know, sometimes students would just kind of whip through it, and I would say, okay, did you check pupils? And they'd say, yep, they're equal and light reactive. And I said, well, you might want to check those again, Landon. And they would go in and check them, and they'd get this funny look on their face because they'd never seen anybody with a permanently blown pupil. So again, the pupils will be unequal, and we'll talk more about that. You talked about altered mental status. That's a key thing that we're looking at here. And in particular, what we're looking here, Aziz, is we have that altered mental status. One of the key things is going to be, does the patient wake up after a brief loss and then later on their mental status begins to deteriorate? Or do they stay in an altered mental status, Miriam, constantly? The symptoms that you're going to see are going to depend upon where the injury is. Now, let me just simply ask you a question. Think back to your anatomy and physiology and the different parts, Muna, that the brain controls. If you had a patient that has an injury to the frontal lobe, what do you think you might see from that patient? Say it again. Memory loss. So very good. So definitely memory loss. Good, Miriam. What else? Change of personality. Now keep in mind the frontal lobe is what gives us our personality. Rihanna, your frontal lobe is what makes you, you, and not Devin, thank goodness. So keep in mind, the big thing that you're going to see is, particularly with people with frontal lobe injury, would be, again, long-term things would be a change in their personality as far as how they're going to act. Now, there's two things that we got to have in the brain for the brain to work at a very, very base level. What are those two things? Glucose and oxygen. Keep in mind that the body can store glucose in several different places. The brain cannot ever store glucose nor oxygen, Lewis. It is a glucose and oxygen hog. So any time that we see any type of alteration within the brain as far as the level of oxygen and glucose, when it drops down below a critical level, our patient is going to begin to have these signs and symptoms that we've all talked about just now. And so that's one of the critical things to look at. Again, one of the few always in medicine is that anytime your patient has an altered mental status, one of the vital signs that you need to get is the blood sugar. Always. End of story. Okay? So just kind of burn that into your brain as far as when you're looking at. Now, the other thing that we've got to have in the brain is, number one, we've got to have adequate pressure in the brain, in the vascular system, to perfuse the brain. And number two, there's going to be some type of a regulatory system to maintain that pressure. Isabella, if we lose that regulatory system, two things can happen. One, our pressure can go sky high, as we will see with a lot of classic types of head injuries, or our pressure can bottom out. Either way, Colin, we lose perfusion to the brain. And again, you all already know that when the brain dies, there is no regeneration of tissue for our patient. Now, the brain is mostly water, probably about 90% water, but it's really, really dense. As such, it lacks an adequate ability to regulate the pressure itself. But what it can do, Muna, is it can come about as we get additional pressure, swelling, either from blood or from inflammation, can begin to put pressure on the vasculature, making the vasculature smaller. As a result of that, we get decreased perfusion to the brain, even though we've got a blood pressure that is literally going through the roof. So, if this regulatory mechanism of keeping an adequate pressure to the brain was not in place, basically, Martina, when you got up to stand up to walk out at the end of class, you'd pass out because your brain needs some additional blood when you stand up. Your pressure in your brain is lower right now with you sitting than it would be with you standing. The nice thing about that is that it is, for the most part, done automatically. We've all had those instances where we've stood up too quickly and start to move, and we get a little bit dizzy for a couple seconds, and then everything regulates out. That's that regulatory mechanism that we talked about as far as maintaining perfusion into the brain. And again, with that perfusion comes both oxygen and glucose stores. So let's look at this just a little bit closer. Within the brain, we're going to look at a couple of concepts. One is known as cerebral perfusion pressure. Cerebral perfusion pressure is the amount of pressure that's needed to push blood through the brain. Now, give me an example of what might cause the CPP to have to go up. What kind of blockage? A blockage where? Yeah, so if we have a blockage coming from like a stroke, we'll talk about strokes in this class as well. But if we get a blockage, a partial or a complete blockage, but in particular a partial blockage, because the lumen of the artery or the diameter of the artery has been narrowed, the CPP has to go up, and the body will automatically do that for us. Give me one other thing, Sydney, that can cause CPP to have to go up in order to maintain perfusion. Say it again. Not decrease blood volume. Lewis. Hadn't thought about that, but yeah, it would. Because as you would increase, there would be some changes on the pressure. Not a lot, but there would be some changes of pressure within the brain as well. Okay, that's a good one. Good one. The one I was thinking about was like trauma, Rihanna. So when we've got trauma, remember, we're going to have two processes that begin to happen. Number one, the brain is very vascular disease. It bleeds freely. I mean, it bleeds a lot. The other thing that you got to keep in mind, Benina, is when we have any kind of trauma, we automatically will get a response from the inflammatory system. As such, we begin to get swelling. If you've had a sprained ankle or a sprained knee or a pulled muscle, you know that swelling is part of that, and that's part of that inflammatory system. Both of those are very good things, but with all good things also comes some downside in the fact that it's going to increase the CPP of the brain as far as when it's going through. Now, there is a direct correlation between CPP and MAP. MAP stands for mean arterial pressure, okay? Now, CPP and MAP also give us a good indicator of what the ICP is. We got all kinds of these acronyms. So, what is the ICP? Yeah, intracranial pressure. All right, now keep in mind, right now we've all got ICP going on. The problem is when ICP rises too much or if it were to drop too low. With head trauma, we're more concerned about ICP going up. Again, there's a direct correlation between your CPP and your MAP and the ICP that's going up. Now, when we're talking about MAP, MAP, Colin, what does MAP, mean arterial pressure, what does it measure? It's an important vital sign. But what exactly does it measure? Good. Okay. You're like 90% of the way there. Good. Can anybody add the other 10%? That's actually going to be more like CPP. So your MAP is exactly what Colin said. It is the average that's found within the arteries from the beginning of one cardiac cycle to the beginning of the next one. Blood pressure is important. There's no doubt about it. But particularly when we're dealing with trauma, MAP is also incredibly important. A normal MAP is somewhere between 85 and 95 in adults. Now, here's one of the nice things. If you use an automated blood pressure cuff, it will give you your MAP on the monitor. It will calculate that for you. Now, I'm going to give you the formula because there is some argument, and I kind of lean this direction as well, not just simply because it's how I learned, but there is some science behind it that says taking a manual blood pressure is actually more accurate than the blood pressure that comes from your monitor. Now, one way to determine that is at the beginning of your shift, have your partner sit down, take the blood pressure with a blood pressure cuff. About 2 minutes later, hook the monitor up to your patient or to your partner and take their blood pressure as well. Do this as part of your equipment checkoff. If it is within about 5 millimeters of mercury for both systolic and diastolic, then your blood pressure machine on the monitor is calibrated correctly, so you're okay. All right, so you can kind of use that. And you don't have to do this at the beginning of every shift, but just once you're utilizing a particular type of monitor, Colin, and you are using that particular monitor, that kind of gives you a pretty good correlation between what your manual blood pressure is going to be, as well as what you're going to see with the automated blood pressure. Now, here's some numbers for you that you need to know. So again, what did I say was the normal MAP for an adult? 85 to 95. Now, the normal intracranial pressure, which is what most all of us are experiencing in here right now, is about 15 millimeters of mercury. Anytime we're measuring pressure, we always measure in millimeters of mercury. That comes into play with a cerebral perfusion pressure of 70 to 90. So you can see the normal CPP and a normal MAP are relatively close to each other. Right? Now, so we're going to talk a little bit about what happens when pressure goes up in the brain as well as when it goes down. Now, the key here to keep in mind is that any sudden change of blood pressure in the patient's body will also have a dramatic effect on your patient's ICP. So, for example, Muna, normal ICP is how much? 15 millimeters, 15 mil, ICP. If your patient suddenly loses 2 units of blood because of trauma, is that ICP going to go up or is it going to go down? You're right, it is going to go down. So somebody else help her out. Why will it go down? You lost fluid volume. And volume leads to what? Volume leads to pressure. You're right. So volume leads to pressure. The body will try to correct for this. In our shock lecture, we talked about compensated, decompensated, and irreversible shock. Hint, 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 you will see considerable amounts of questions on your exam about those 3 areas. But the body will try to compensate as much as it possibly can. And as a result, the ICP will be maintained for a while. But if we don't stop the patient's bleeding, then the ICP will begin to drop and we will have an altered mental status. Now, even more important than the cerebral perfusion pressure or the CPP is the volume of blood that actually flows through the brain. Now, Aziz, why would volume be more important than pressure? Say it again. Good. So remember, you can have a great pressure, but if you don't have enough of those red blood cells to perfuse the brain's going to begin to feel deficient in oxygen and glucose. So again, this is critically important. This is going to be something that you're going to want to watch in your patients, because when we have a patient with a head injury, all y'all are EMTs, you expect your blood pressure in your patient with a head injury to do what? Up or down? Go up, okay? If you've got a patient with an obvious head injury and they've got a low blood pressure, tell me what's happening. As a result of what? So they're in shock. Why? Yeah, you're exactly right. You're exactly right. So the patient has lost a lot of blood. So if the bleeding is not obvious, look for bleeding internally if you can do it upon your assessment. Again, this is why your assessment skills are so very important, because in many situations we're human. Out of sight, out of mind. If we see a patient, Martina, with just bleeding and bleeding and bleeding down on the side of the road, that gets our attention. But if the bleeding's internally, we go, okay, maybe this patient isn't as bad as what I thought, when in reality, they could be critical, Lewis. So again, any head injury patient with a low blood pressure, look for bleeding somewhere else. Now, the thing that we're looking at here is that the brain works really, really hard at a concept known as autoregulation. Autoregulation is what we talked about a while ago. You go to stand up, the body automatically senses it. It causes vasoconstriction or vasodilation as the need is, and keeps blood going to the brain at a constant rate and volume under different types of circumstances. Now, it does this by way of 2 concepts. One, baroreceptors, and number 2, chemoreceptors. Now, if you were in my EMT class, I talk a lot about baroreceptors that are in the lungs, okay? Baroreceptors in the lungs are there primarily to keep us from overinflating the lungs and giving ourselves a pneumothorax every time we take a deep breath. But the vasculature also has baroreceptors and chemoreceptors as well. Baroreceptors are found primarily in the aortic arch. The ones that we're concerned about, particularly for head injury, are the aortic arch and in the left and right main carotid arteries. These baroreceptors are always monitoring pressure, barometer. So they're monitoring the pressure in particular to the different organs of the body. That's the one that comes off of the aorta. But also the two that are monitored within the left and right main carotid arteries are monitoring the pressure so that we have a good pressure volume going to the brain. The only thing that they do is dilate and constrict. That's it. Okay. It sends a message to the brain. Hey, Rihanna is standing up. Constrict the carotid arteries so that we maintain pressure going to the brain. Or now she's sitting down. Let's open up those carotid arteries so that the pressure will drop a little bit. Chemoreceptor. Martina, do you have a question?
So I think we have that. So why is it not as a good monitor for older?
Ooh. So why do baroreceptors, why is it that older people have a tendency, this is going to be true for their chemoreceptors as well, that we'll talk about in a second. Why do baroreceptors not work well for geriatrics? Say it louder. It has to do with the elasticity. You're right. They'll still have as many. Yeah, so the receptors that you're born with are still functioning, but you're along the right pathway there, both of you. Tell me more. One more time. Yeah, that's one of the things that stinks about getting old, okay? So whatever y'all do, don't get old, all right? Is that the body systems begin to wear out. So those baroreceptors, even though we still have the same number, they've been worked and they've been worked and they've been worked. Now, a couple of things happen. Number one, they're not nearly as receptive as what they used to be. So it takes more to cause them to act. The other thing is to keep in mind that one of the things that happens as we age is we start getting calcium deposits within the tunica media. The tunica media is what part of the arterial system? The middle, okay, the muscle part. What happens to the muscle when we get calcium deposits within it? Say it again. It gets stiff. Yeah, you're exactly right. So as these calcium deposits begin to build up, now the muscle cannot constrict anymore, because think of calcium as kind of like little teeny tiny stones, Isabella. They're in there and they've caused the muscle to become calcified. And calcified muscle is basically just really tough. It doesn't move. Again, that's a great question, Martina. And the rationale is because of they've been worn out, and the older you get, the more calcium you're going to get in these. This is one of the reasons why you guys will get it. It'll probably be some type of new device, but I would dare say all of your parents have received some type of a notice for a free screening of your carotid arteries. And what they're looking for, they'll go in with a little machine and they'll do an ultrasound looking at your carotid arteries to look for both calcium in the muscle as well as calcium on the lining of the tunica intima. That's your lining of the artery. The higher the amount of calcium, the greater the potential for heart attack and stroke. Isabella. You can slow down the process by eating well and exercising. You guys can begin that process right now. Another big thing is there's a huge amount of research is coming out about how important adequate sleep is. Now, I'm not going to tell you what you have to do, because y'all, almost everybody here is working EMS. That's why you look the way that you do now. You're going to wind up looking like I do. You don't want that. But the big thing is, by living a healthier lifestyle, you can push that out. So you guys still have a chance. All right, very good. So chemoreceptors then, they measure, again, particular types of chemicals within the body. Chemoreceptors from a cardiac perspective, again, this comes into play with trauma, measures what two types of gases? Carbon dioxide and oxygen, all right? So why is this so important? Well, having an adequate amount of carbon dioxide in the blood causes vasodilation. In the old days, it used to be that we would bag our patients. We brought patients in, bagging them at 40 breaths per minute. We were so proud of ourselves. We would have not SpO2s, but we would have what's known as a PaO2, which actually measures the content, the volume of oxygen that was in the blood. We would have numbers up in the 200s. It was awesome. We killed every one of those patients. Every single one of them died, even though we thought we got to get more oxygen to the brain, got to get more oxygen to the brain. Again, this goes back to what I shared with you, is that at least 25% of what I'm telling you in this class is going to be malpractice in 10 years. We just don't know what 25% yet. When we blow off carbon dioxide, we cause massive vasoconstriction, which does what to our intracranial pressure? It goes up. It goes up, okay? Again, remember, as the arterial system gets smaller, we begin to get less blood that comes through the body. What do cells do when they're hypoxic? They begin to swell, all right? Why? Because there's too many waste products that's not being carried away. So as we begin to get this swelling that's going on, and we get a critical mass here, Brianna, of cells in the brain that begin to swell, now our pressure in the brain goes up. What does that do, Lewis, for our CPP then? Does that increase our CPP or decrease it? It increases it. Yeah, it increases it. All right. Ultimately, that leads to our patient herniating and dying, okay, as a result of that, as a result. So again, even though we used to bag our patients at about 40 breaths per minute, the absolute most you're going to bag your head injury patient is going to be somewhere around 20, and determined by what, ladies and gentlemen? Somebody might be proud. Thank you. Yeah. Again, and I owe no stock in the end-tidal machine business, but you're going to determine your respiratory rate by looking at your monitor and looking at end-tidal. As CO2 goes up, guess what you're going to do with your rate? We're going to breathe just a little bit faster. As it comes back down, then we're going to breathe just a little bit slower. More about that in just a minute. Okay, so baroreceptors monitor pressure. Again, aorta, carotids. Chemoreceptors monitor oxygen and CO2. Where will you find, what location is the most important location for chemoreceptors? It's a part of the brain. Medulla, yeah. Why the medulla? Because the medulla is your brainstem. That's what controls your vegetative functions. And so the medulla has the best chemoreceptors going on. And that's what causes you to increase your respiratory rate and your tidal volume when your CO2 begins to go up. And it causes your respiratory rate and your tidal volume to go down when your CO2 is down. So that's what drives your respiratory rate as well as your tidal volume. Now, if your CPP drops, there's only one way by which the body can maintain perfusion into the brain, and that's by providing more blood. All right? Now, it does this either by constriction or dilation of the vasculature. If the CPP, which the normal CPP is what? 70 to 90. When I repeat myself again, it's probably because you're going to see it on an exam. 70 to 90. If it drops below 50, if your CPP drops below 50, remember we talked about that auto-regulatory mechanism that keeps constant blood flow going to the brain. So that when Martina stands up, she doesn't pass out. She just simply is able to walk. Now that auto-regulatory mechanism begins to fail. It doesn't work, which can lead to what for our patient? Mental status. Mental status, if you'll think about it, old saying used to be, in minds back around the turn of the century and even earlier, they would put canaries in the mine because the canaries would die quicker from the methane and the carbon monoxide that would often build up in there. So when you hear me use the phrase, it's the canary in the mine, that's your early warning system for your increase in intracranial pressure as well as the decrease in perfusion is exactly what you said, Lewis, is that altered mental status. And if it drops below 50, that becomes even more dramatic as far as it's going through. All right? So you want to kind of keep that in mind. Now, as bad as that is, it gets worse because in order to have enough blood coming through, and part of this auto-regulation system, it has to increase the pressure. Now remember, and we kind of touched on this a minute ago, is that we're increasing the vascular pressure, which means our MAP is also going to go up, but we're also increasing the pressure on the vessels themselves because, Rihanna, we have blood in the brain that is loose, free blood, and we have the inflammatory process that's going on. Think of it like this. Your brain is a sponge, just a great big sponge with little straws, very flexible straws that are running through it. If we squirt a bunch of water into that straw and it's contained within a closed container, all right, what's going to happen to the pressure within that sponge? Say it again. It's going to increase. Why? Yeah, you're filling the space, but normally when we increase volume, it expands. But if it's in the skull, and for all means and purposes, there's only one place that any expansion can take place, and that's what? And that opening is called what when the spinal cord comes out? Starts with F? Foramen magnum. Foramen magnum. So as that expansion begins to come out, guess what gets squished out like toothpaste? What's back here? The brainstem. The brainstem. Remember, the brainstem is what controls everything as far as heart rate and breathing. They start posturing, and we'll talk about that in a minute. Knowing which posture is worse. Neither one of them are good. There's only two, but one is as my friend in Texas would say, more worser than the other. So the thing that we're looking at here is that we get this blood and we get the swelling. Now it makes it even worse to put pressure on the vasculature in order for blood to get through. As that pressure goes up, oxygenation and glucose delivery goes down. Like I said before, the brain is an oxygen and glucose hog. It will use as much as 20% of both oxygen and glucose that's delivered to the body. That's more than any other organ. The other thing to keep in mind is that the more specialized an organ is, the less likely it's going to be able to regenerate. Now, the brain can't regenerate at all. When you kill off your brain cells, they're gone forever, whether that's done through drugs or alcohol or trauma. When they're dead, they're gone forever. If you get a drop in your oxygen or glucose, your patient's going to start acting weird. They're going to be acting strange. This is why it's so incredibly important at the very beginning of your assessment that you establish some kind of baseline. That baseline may be completely abnormal. So a patient may be talking to you, Rihanna, and they may say, I'm in London, England, okay? That's your baseline, because what you're going to look for now, particularly with head injuries, this is what we're focusing in on right now, is that as time goes by, is that altered mental status getting better or is it getting worse? And that's going to be critical as far as identifying the type of bleeding that we've got going on and what you can expect to be with this patient. Because trust me, some of you guys are going to be working in some remote places. You're going to be with these head injury patients for a while. And so you want to be able to kind of plan out ahead as far as what's going to happen. So consider the level of consciousness as part of the patient's early warning system. You're not going to know whether they're getting better or worse if you don't get that baseline. Now, when we're looking at these patients, as we said a while ago, carbon dioxide plays an incredibly important role on the constriction and the dilation of the vasculature within the body, but especially within the brain. Now, this is never more important than we're dealing with brain injuries. So, again, anytime you have a patient that has any kind of an altered mental status that you suspect is coming about as a result of a TBI, that patient needs to be put on your end-tidal CO2. You've got to measure that to get a baseline, Lewis, and then to watch as it is progressing. If intracranial pressure is increasing, what do you think would happen with your end-tidal numeric readout? Keep in mind, the normal for your normal CO2 in the body is what? 35 to 45 millimeters of mercury. We're doing that in pressure. Let's say that all of a sudden now, your traumatic brain injury patient, Miriam, now has a end-tidal reading of CO2 of 48. Why might that be? Say it one more time. Increased ICP. That's the reason why. Again, you're going to watch that and you're going to trend up, and those small changes in that numeric is going to give you early warning. So in that particular situation, especially if you're bagging your patient, then that's going to be your signal. We need to bag faster and deeper to bring that down or to raise that up, depending upon what's going on. Yes?
Why don't we use stuff like hypertonic saline to drop the pressure?
If we use hypertonic solutions, it's only been recently that most of the EMS agencies have started carrying IV pumps. Okay? In the past, we always just gave our IV meds and our fluids by gravity, which was a terrible way to do that. We'll spend $30,000 on a cardiac monitor. We won't spend $5,000 on an IV pump. That's changing. Part of the problem is when you're bringing the pressure down in the brain, you must do it slowly. Because if you bring the pressure down in the brain too fast, you can cause your patient to stroke. And if they stroke, because basically what happens is you get a sudden vasospasm that's going on, or if it brings it down really quickly and there is a clot there, by causing rapid dilation, you can dislodge that clot and cause your patient to have an ischemic stroke. So this is one of the reasons why we don't use things such as nitroglycerin to lower a blood pressure, because we have no control over it. When you get to the hospital, if your patient has an extremely high blood pressure, whether it's from a hypertensive crisis if it's from a traumatic brain injury, they're going to bring that pressure down slow, because you don't want to take a bad situation and make it even worse. Is that clear? That's a good question.
So it's not a matter of we can't do it, it's just a matter of we can't regulate it as well?
Yeah, yeah, because you're literally looking at hours or potentially a day and a half or 2 days to bring that pressure down. In that particular situation, our goal is to try to maintain perfusion going to the.
So it's just a matter of there's not enough time to do it to make any difference. Is that what I'm trying to, is that what I'm
To a certain degree, the greater danger is going to be, because remember, when your patient gets into ICU, they're going to have as many as 10 or 15 people working on them. In many situations out there, it's going to be you and your partner, okay? And so that's kind of one of the things that we look at, because perfusion is going to, at that point in time, is going to be more important than bringing their pressure down. So again, when we blow off CO2, we cause vasoconstriction. That's why we want that CO2 to be at a certain particular area. Now, again, if we hyperventilate our patients by breathing too fast and too deep, not only, as we've talked about in here, can we reduce perfusion to the brain by causing vasoconstriction, how else can we reduce perfusion to the brain, not only in TBIs, but across all types of problems that your patient may be able to have, whether it's medical or trauma? How else does hyperventilation lead to poor perfusion? Not so much blood gas exchange.
Just not enough volume?
Think about the mechanics. If we hyperventilate, what's going on in the chest? Why? Yeah. Remember, we've got these two lungs on either side of our heart, okay? If we overexpand the lungs, guess what they're doing? They're putting pressure on the heart, which means what? The heart cannot expand. Remember back in 303, we talked about Starling's law? What is Starling's law, or the Starling principle? Yeah, but if we're squeezing the heart, how much is the heart able to stretch? Not much. That's one thing that leads into decreased cardiac output. The second thing, and we'll talk particularly more about this when we get into SVT in advanced cardiology, is remember what happens to the heart rate when we put pressure on the vagus nerve. It decreases. So now we've done a double whammy. We've in our patient that has a brain trauma. If we blow off CO2, we've caused vasoconstriction, we've reduced perfusion. If we're hyperventilating, we're keeping the heart from being able to fully expand to get all the blood in, Isabella, that it needs. And wait, there's more. We cause the heart rate to drop, Martina, because we're putting pressure on the vagus nerve. Again, when you're ventilating your patient, squeeze the back half of the bag. Do not put your hand in the middle of the bag. Put it on the back half of the bag. If you squeeze the back half of the bag and you're watching the patient's chest go up, you're getting your patient plenty of oxygen, especially if you're watching your SpO2 and your end tidal as far as going in there. Now, when we're looking at this, it will also lead to a potential as far as a change in the ICP. So you're going to kind of want to keep that in mind. Now, when we reduce circulation, remember, what is the whole premise? You learned about this in your ENT class. What's the whole premise behind an ischemic stroke? You think, we're talking about head trauma. Why are we talking about strokes? But what causes cell death in an ischemic stroke? Lack of perfusion, lack of oxygen. The exact same thing happens when we have increased intracranial pressure. We have lack of oxygen that's going on. Now, when we get our SpO2 that goes up above 45 or down below 35, that reduces our perfusion. That's why you let your ventilations be guided by what you see on your end tidal. The waveform in head trauma is not nearly as important, Sydney, as it would be if we're dealing with, say, like an emphysema patient or an asthma patient. That numeric is what is critically important. And whoever is handling the airway, it's going to be your responsibility to get that monitor where you can see it and you can watch that. Because remember, your SpO2 could take anywhere from 3 to 5 minutes to change. Your end tidal will change in 10 seconds or less. So it is almost instantaneous. Not quite, but almost instantaneous. Now, when we're looking at this, not only are we looking at our rate, but we're also looking at our tidal volume. Again, that's why I stress, squeeze the backside of the bag. Now, as we're looking at these different types of brain injuries that we've got going on with our patient, first of all, we're going to talk about primary brain injuries. When you hear the word primary, what are you thinking in the world of TBIs? Say it again. Yep. Okay. That's good. I heard somebody. What did you say? Direct. If you have a person that gets hit in the forehead with a baseball bat, do you think that that is going to cause some trauma to the frontal lobe? Well, absolutely. Yeah. They get shot in the head. Okay. The bullet is going to cause some direct trauma. So when we're talking about primary injury, we're talking about as a direct result of the force that causes that brain injury. Okay? Now, some of these types of brain injuries that we would see are contusions, which another word for contusion is what? Say it again? A bruise, yeah. So when we're dealing with a bruise, we think, well, a bruise isn't that bad. Well, it depends on where it is. You get a contusion or a bruise, which is simply a collection of blood in the brain. Remember, what will that contusion do to your intracranial pressure? It's going to increase it because it's additional pressure. There's no place for it to go. And again, the inflammatory process is automatically going to start because that inflammatory process disease is what helps us to clot off our bleeding. So we're going to increase that. You get a contusion to the lungs. Again, that can be a bad thing. Why? You get a collection of blood in the lungs, and what's that going to lead to? Poor perfusion, okay? And actually more so than just perfusion, but poor diffusion. Diffusion, because many times you'll get that blood that'll collect in the alveoli. You get fluid in the alveoli, no gas exchange takes place, which leads to our patient becoming hypoxia. You get a cardiac contusion. What kind of problems can a cardiac contusion cause? Not enough mechanical action. What's the other side of that coin? It can lead to a low blood pressure, but, say it again? Low perfusion, but it can also lead to alterations in the electrical conduction system if that area of the heart is affected. So again, when you hear the word contusion, don't think, well, that's a minor injury. Depends on where it is, okay? You get a contusion on your shin, yes, that's a minor injury. You get it on an important organ, not so much, okay? Now, as I said, brain tissue doesn't regenerate. It will heal itself, but it turns into scars, and it will leave a negative impact that will often affect your patient for the rest of their life. Direct or primary brain injuries are usually permanent just simply because of the massive amount of force that occurs. You have a patient that's unrestrained and they go head first into the windshield, the frontal part of their brain, again, that's going to be damaged. It's going to cause a problem. Now, the brain is made up of what percentage of water did I say? Actually closer to 90%, somewhere between, depending on where you read, 75 to 90. I'll never ask you on an exam, Isabella, to tell me what percentage of the brain is made up of water. I just want you to realize it's made up primarily of water. As such, if you've got something that is made up, at least 3/4 of it made up by water, what would be some of the properties of that object? Say it again. It would be mushy, which would lead to what, Colin? Yeah. And that could cause problems how? It can move around. Not much. Remember, it's inside the brain. But remember, the brain has ridges and little nooks and crannies that are sharp. When the brain moves, because the brain's not designed to move, but when the brain moves, it can tear brain tissue on those little ridges that are inside the brain itself. This is where we get this type of injury that is known as a coup contra coup injury. Let's go back to our guy that got hit in the forehead with a baseball bat. The thing that happens is we have primary injury right here. Now, that's going to be permanent. It's going to last forever. But the secondary injury will be as that force is generated into the brain through the skull, it now moves the skull very quickly to the back. And the backside of the brain also sustains an injury. That's your secondary injury, also known as a coup contra coup type of injury. Now, when you're looking at these patients with these secondary injuries, what would be potentially some signs and symptoms? Now, I realize we haven't done pediatrics yet. That'll come next semester. Think back to your EMT and to your pediatric lecture in your EMT. What would be something that you would be able to identify as a potential primary, secondary type of injury in an infant? You're pointing. Tell me more. What are you pointing to? What's it called?
Soft palate.
Soft palate.
Okay, the thingy.
The thingies. Yeah, the thingies. And those thingies are called what? Starts with an F. Fontanelles. Fontanelles. Good. Very good. So, see, I told you I would teach you. Or make fun of you. No, I'm not making fun of you. Anyway, the fontanelles begin to bulge, all right? One of the things that Kentucky leads the country in, and we should be ashamed of this, is in pediatric abusive head trauma. There are more pediatric abusive head trauma cases in Kentucky than any other state, and you're going to come across that. In very young children, infants, again, those fontanelles have not yet fused together. It's actually a safety mechanism for them in the fact that they have a greater chance of physical survival because the plates of the skull can come out a certain bit. The trauma is usually going to be so severe that they're still going to have massive problems as they get older, but they will survive. I don't know if that's better or not. That's left for somebody else to determine. But other things that you can also see in infants that would cause the fontanelles to bulge would be fever as well as crying. So if you see these fontanelles that are bulging in pediatric patients, in infants, don't automatically assume that it's coming about as a result of trauma. It could potentially just simply be a normal aspect of your of the patient. Ultimately, What else can lead to, other than a coup contra coup injury, what else can lead to a secondary injury? We've already discussed this actually. Did you say stroke? Stroke could potentially cause a secondary injury, but I need more details. As a result of what? Now, within here, what we're talking about primarily is going to be trauma. What else can lead? Aziz. As a result of what? You're getting closer. You're still dancing around. Swelling. Swelling, okay? Even if you've got a patient that only has the injury here. So, for example, let's say a patient gets shot in the frontal part of their skull and it's going this direction, all right? Yeah, you're going to have some movement within here, but the other thing that can lead to these secondary injuries is going to occur as the brain begins to swell. Remember, as the brain swells, it can begin to tear some of the veins and arteries that help to feed the brain itself. The other thing that it does is it causes a crushing of these different brain cells, which is kind of a vicious cycle. When we have a crushing of the brain cells, it leads to more inflammation, and as a result of an increase in inflammation, it leads to more what? More what? More pressure as a result of swelling. So one of the key things that we can do is that we try to reduce that swelling. And what is the one thing, and we've already talked about it, but what is the one thing that you are able to do that can help? You won't correct it, but you can help to do to bring down that swelling. Either decreased or increased ventilation, depending upon what your end-tidal is showing. So the ventilation that you're going to do or not do is going to be critical as far as what you're going to see with these patients. Again, when we have the swelling, it leads to hypoxia. Hypoxia leads to more swelling as the cells begin to develop more waste products, and it increases the swelling. So literally, we get into a vicious cycle. This makes our patient much more acidotic. Remember, when your patient is acidotic, what happens to their ability to stop bleeding, to clot off bleeding? It goes down. So even if the only place in your that your patient is bleeding is in their brain, that bleeding is going to continue. Many times, a patient that has a motor vehicle accident, that's not going to be the only place that they're going to be bleeding. So again, we want to try to keep our patient from becoming acidotic. When we're looking at this, again, it kind of gets into to this vicious cycle. Now, there are some situations in which this swelling can take place over a number of hours. Give me an example from a pathophysiological. I'm not looking for a disease process or a mechanism of injury, but what structure of the brain would be injured that would cause the swelling to take 4 to 6 hours to develop and to show signs and symptoms? Give me an example of an injury to the brain, not mechanisms. I'm not looking for baseball bat to the head or gunshot wound. From a pathophysiological perspective, what would cause swelling in the brain to take hours to begin to develop and to exhibit signs and symptoms, as opposed to a similar but different type of injury that would cause swelling and onset of signs and symptoms to happen in a matter of minutes? Okay, so now I love the fact that you guys are focusing in on strokes because there is much similar between strokes and trauma, but let's limit it solely to trauma related things for right now. Okay, that's a mechanism, or that's a specific diagnosis. I'm looking for more of a mechanism or a pathophysiology that's happening. Aziz, direct injuries could cause either one of these. Indirect or primary secondary injuries could cause either one of these. Think from an anatomical perspective. What structure? Don't the structures that I'm thinking about are found everywhere in the body. Say it again. What about the vessels? Now we're getting closer. What vessels? Okay, so you're going to kick Isabella? The one that feeds the brain, yes. If you have venous bleeding as opposed to arterial bleeding, which one is high pressure? Which one's going to put out more blood? Which one do you think you would see the quicker onset of symptoms? Arterial. So you can have a patient that tears or injures one of the cerebral veins and it will leak because it's low pressure. Okay? It will leak. Your patient will usually have a headache that will continue to intensify, Landon. And then over the next few hours, the patient's level of consciousness will begin to go down. Why? Because it takes longer for that pressure to begin to build up from the volume of blood that's coming out of the vein. We have lower volume, it takes longer, as opposed to an arterial bleed, which is higher pressure, higher volume, and you will see quicker onset of symptoms. Why is that important to you? Because if you get there and your patient is unresponsive from the time that the incident happens, you can almost be assured, Benin, that there is arterial damage involved, which makes your patient much more critical. That doesn't mean that the patient that's bleeding from a venous injury is not critical, but they have a little more time that's going to be on their side simply because the bleeding is so much slower. Again, when we're looking at these patients, watch your end title on them. We've talked about primary injuries. We've talked about secondary injuries. In the last few minutes that we've got, let's talk about focal injuries. Okay, now in EMT class, you learned about focal motor seizures. What are those?
Localized seizures.
That exhibit themselves how, Lewis? Good. Take us home there.
Almost like tremors on one side of the body.
Yeah, so they are relegated to one part of the body. Okay, tremors is a really, really good way of describing that. That comes about as a result of you have one part of the brain that is misfiring and going off. A focal type of injury is very similar. You have one tiny area of the brain that has been injured, and it depends upon how much and how severe the bleeding is that comes into play here. A contusion is a very similar type of a focal type of injury. A contusion is located to one part of the brain, and it comes about as a result of bleeding that collects either within the brain tissue itself or on the surface of the brain. Contusions are very, very common. Your patient will present as being confused, Miriam. They may have other types of neurological deficits that are usually going to be transitory and temporary simply because, going all the way back to what we talked about at the beginning of class, that autoregulation mechanism of the brain that's keeping perfusion going on. Now, Martina, is it possible that we can have multiple focal injury sites on the brain? If we have that, Sydney, if you get me the right answer, we'll leave now. Give me an example of a mechanism of injury that could cause multiple focal brain injuries. Somebody help her if she struggles.
Like hitting two sides.
Tell me more.
Like, I think frontal car crash.
Yep.
You would hit like the back, the front, or like the
How would the back get injured?
with the seat.
With the seat. Now, the seat is there to protect primarily your neck. If it's too high. So if it's too high or if it's too low, that actually leads to an increase of neck injury, not head injury. But I will tell you, she's on the right manner. Sydney, did you have an answer? Isabella's going to come to your rescue.
I don't know about that. Could it also be like your secondary injury?
Exactly. And that's also known as what? Starts with a C. Coup, contra coup injury. Keep in mind, as we're going through here, the coup contra coup injury would not be directly opposite, again, because the brain is kind of like jello. If you've got a bowl of jello here and we drop it on the table, not so much that it spills out of the bowl, but the whole thing just kind of moves independently of other parts of the bowl of jello. So literally you can have an injury here and that would be your coup injury, one focal point of injury, and your contra coup or another focal injury could be over here. Why? Because it just kind of vibrates around like that. Have I confused you? Okay, so hopefully this will work. I'll get this converted and I'll put on the blackboard. So if you need to review it, we'll do so. And